Okay, ladies and gentlemen, committee, it's 3:30, so we'll go ahead and get this meeting started. First thing on the agenda is requests for bill introductions. Are there any? Seeing none. Thank you, folks. We'll move on. We have a presentation today. We're continuing our 101 episodes, and today we're going to have an overview of the Kansas Department of Aging and Disability Services, KDADS, known to you acronym aficionados. And I welcome Laura Howard, Secretary. Welcome.
I'm pleased to be here today to talk with you about KDADS and a bit of a KDADS 101. You've got a short slideshow in front of you, but a couple things I might just say before that is KDADS is a large budget. And we won't talk budget today at any length because you'll be digging into budgets here in a couple weeks. But just to give some context to it, the KDADS budget and the governor's recommendation for 2024 is almost $2.9 billion. So it's not a small agency by any means, and the vast majority of the funding within KDADS has to do with the Medicaid program in some fashion, whether we're talking about nursing facility programs or the home and community-based services waivers. So, KDHE is the state Medicaid agency, but I like to say that KDADS is the other Medicaid agency because we are, if you think about Medicaid services for people who are aging, whether they're in the community or in a nursing facility. If you think about services for people with disabilities, ranging from physical disabilities to a developmental disability, intellectual disability, that's KDADS. And then the other primary area, again, also a lot of Medicaid in this area as well, behavioral health. So again, we'll work through just kind of some of our programs, try to give you just a high-level overview of who we are and what we do. But I think it's kind of an important context. I mean, just the magnitude of resources that are within the KDADS budget. You have on the second page an organizational chart for KDADS in terms of our senior leadership staff. I have a couple folks with me here today that I'd like to introduce. The first is Scott Bruner. Scott is our Deputy Secretary, and he leads activities related to hospitals and facilities, our state hospitals, as well as our facilities programs. I might also have with me here today Lee Keck. Right behind me, who's our Director of Governmental Affairs. You actually have her contact information on the next page. So anything you need from KDADS, she's around this building a lot. Reach out to her and we'll make sure we get that back to you. But if you look at that organizational chart, kind of on the left side of the chart, some of the maybe administrative positions, our legal counsel, our HR director for state hospitals, Brad Ridley, who is our Director of Operations. You'll probably have some contact with him during the budget process. He's kind of all things budget and finance and procurement and all of that. And then on the right-hand side of the chart, you'll see to the right of Scott's name, we have the Commission of Long-Term Services and Supports. We have that's currently led by Mandy Flower, our interim commissioner, and you've already had the chance to hear from her. Andy Brown, our Behavioral Health Services Commissioner. Lacey Hunter, who's Commissioner of our Survey and Certification Functions. Mike Dixon, who's our State Hospital Commissioner, as well as the Superintendent at Parsons. And then our PIO also shows up there. So that's kind of our senior leadership staff for KDADS. On page 4 of the diagram, we did put a map for the state hospitals. KDADS does oversee the 4 state hospitals. They do have independent budgets, so you'll review those budgets independently. But we have 2 state hospitals for individuals with intellectual and developmental disabilities. Those are Parsons State Hospital and Training Center down in Southeast Kansas, and then KNI, Kansas Neurological Institute, here in Topeka. We then have 2 psychiatric hospitals, Osawatomie State Hospital, in Osawatomie, and then Larned State Hospital out in Larned. And we'll say a little bit more about some of those roles a little bit later in the presentation, particularly as it relates to Larned. It's a bit unique as it relates to the state hospitals in terms of the scope of what's provided at that particular facility. Those state hospitals, range in bed size across those state hospitals from daily censuses of about 126 at KNI to 158 at Parsons to 128 daily census as Osawatomie, and then over 400 at Larned. At Larned, the most significant population by number are those individuals who have been civilly committed to the state sexual predator treatment program that is part of Larned State Hospital. So again, not the general psychiatric beds, but a civil commitment program under Kansas law, where individuals who have finished their sentences related to sexual offenses can be civilly committed, and that program functions at Larned. So again, just kind of a high level that we do manage those 4 facilities.
Madam Secretary,
Yes.
would you go over those numbers again, the over 400 at Larned, and what were the
Sure.
other numbers?
Sure. Yeah, so Larned, 419 daily census, Osawatomie, 128, KNI, 126, Parsons, 158. And that's why I said Larned is very different, because Larned really has 3 programs. It has a state security hospital that would be similar to Osawatomie. It has a state security hospital that's licensed for 90 beds that has to do with forensic evaluations for competency and restoration and some forensics placements. It has 245 beds related to the sexual predator treatment program, and then 72 that are general psychiatric. So the 72 would be more parallel to what you see at Osawatomie State Hospital. So again, I always like to mention that, because Larned is just a little bit of its own animal. It has a breadth of programs, and it's not just a traditional state psychiatric hospital. Page 5 of the presentation. So within KDADS, we have 4 major program areas that are organized through our commissions. The first is the Long-Term Services and Support Commission, and we'll talk in a little bit more detail about each one of these. But we have the Long-Term Services and Support Commission, we have the Behavioral Health Services Commission, we have our Survey, Certification, and Credentialing Commission, and then our State Hospital Commission. I'll start with long-term services and supports. This is the largest in terms of funding and programs across KDADS. I'm on page 6 of the document. This commission really is where all of the community-based aging and disability programs fall, as well as the program side of nursing facilities. So within the long-term services and supports program, the state's home and community-based services waivers are managed there. And I'll talk about those in just a minute. And I know you have a full presentation on waivers on Thursday, so I won't go into a lot of detail today. But it's important, because they serve a significant number of people, cost a significant number of dollars, and a lot of policy conversations around those. So within this commission, as I said, the home and community-based services programs fall within the commission. So do aging services. So if you've got a senior center where you live, if there's meals programs for seniors, the funding for those services probably came from KDADS through the federal Administration on Aging. So again, the Older Americans Act programming and funding comes to us from HHS. The biggest program is senior nutrition. There are other programs as well. Under aging services, there's also a state-funded program that's similar to the waiver programs called the Senior Care Act that this legislature funded, gosh, probably 30 years ago now, to provide some in-home supports to individuals to allow them to stay in their homes. Individuals who aren't Medicaid eligible. We also award funding to PACE programs in the state. And those are programs that provide kind of comprehensive services in the community, combination of Medicaid and Medicare. It's the program of all-inclusive care for the elderly. And so we have a few of those programs in Kansas and an expansion plan there as well. And then under long-term services and supports, we also manage the nursing facility program and reimbursement for nursing facilities. So the programmatic regulations and the rate setting fall within this commission. When I talk about survey and certification, that's where all of the licensing and regulation happens with regard to the facilities. So again, this is the commission that has the vast majority of the funding within KDADS. I will say just a little bit about the home and community-based services today on the next page. You know, we call these the waivers. They're called waivers because for states to operate these programs, we have to get permission from the Federal Center for Medicare and Medicaid Services to waive certain kinds of Medicaid requirements. You know, sometimes when you get a waiver, that's to waive requirements for freedom of choice. For these home and community-based services waivers, what they really allow us to do is to provide certain kinds of in-home services that you wouldn't otherwise be able to provide under Medicaid. They're for specific populations, and they're for individuals who, without these services, would likely be living in an institutional setting. So again, we operate 7 of these waivers. You know, Kansas was, you know, has had many of these waivers in place, I mean, for, you know, a couple of decades or more. The waivers range from the smallest, right now, the autism waiver, serving 58 people, to the largest being the intellectual and developmental disability waiver, serving 9,000 people. And again, we'll have those numbers when I come back and talk with you on Thursday, but just to give you a context. So for example, the frail elderly waiver, think about an aging senior who needs personal care supports, needs help with bathing, dressing, might need help with meals. They can get those services and supports in their home from a personal care attendant. Think about the physical disability waiver. It serves about 6,100 Kansans. These may be younger Kansans who have a disability, and you know, perhaps they have a physical disability that means they're unable to move certain limbs. They may be working full time, but they may need assistance to, you know, again, to do those basic activities of daily living, to get out of bed, to be clothed, those sorts of things. So again, a range of services on the different waivers. We'll go into more detail on that. Again, significant part of the agency's budget. 2 of these waivers have waiting lists. One we talk about quite a bit, the IDD waiver, with 4,800 people waiting for services, about 2,400 on the physical disability waiver waiting for services. In terms of just some priority areas right now within the Long-Term Services and Supports Commission, there's a lot of activity going on that I highlight on page 8. The first item has to do with some spending for some special projects that have been funded, that were funded through one of the federal relief bills. Essentially, the federal government allowed the states to use a 10% enhancement to the state's Medicaid rate and to use the state funds that were left over from that 10% increase to invest in certain kinds of areas. The biggest one we invested in was about $50 million in direct workforce supports. When we think about these home and community-based services waivers, when you think about kind of the workforce challenges that are out there, some of the lowest paid direct care workers and support workers, work in conjunction with these types of services. And so we spent about $50 million in some recruitment and retention bonuses. We have a number of other projects going on as well related to things like, study and evaluating the waiting list, and some things to do with what does it really mean to be an employment first state, really services to do with employment for people with disabilities. So a couple of projects out there that are being funded through that federal project. Another area in long-term services and supports that you'll hear a lot about is what's called the final settings rule. And this is actually a regulation that was passed, I think, all the way back in 2014 by the federal government. But the basic context of the final settings rule is that people who are receiving services through home and community-based services, really ensuring that that their lives are integrated and inclusive in the community. This has been very, very intensive work with providers, including assisted living facilities, to ensure the choices of residents are honored, to ensure that people are involved in the community and things like that. Again, we can go into lots more detail about that, but that's been a major project, really having to look at, several thousand settings across the state to see if they're compliant with this federal requirement. Another facet of managing HCBS waivers is that you have to renew them every few years, and that's its own process with the Federal Center for Medicare and Medicaid Services. We're in the process of 2 of those waiver renewals this year, autism and the waiver for kids with serious emotional disturbance. We're also in the process of submitting certain amendments to the waiver that would allow certain opportunities for family members to be paid in certain cases as caregivers, some telehealth pieces, and some changes in performance measures based on some new expectations from our federal partners. I mentioned earlier the expansion of the PACE program. Our partner, Midland Healthcare, is expanding PACE. They have an application to expand to the Johnson County area. That'll be a significant expansion of PACE. And then we recently received a Money Follows the Person grant. Kansas has had these again. What that means is if there are individuals who are in institutional settings, for example, could be a nursing home, could be another institutional setting, who want to live in the community. This is a planning grant, and then it'll be an implementation grant that allows resources to be wrapped around those people as they might move back to the community. So again, just a few of the things going on within the Long-Term Services and Supports Commission. And then on the next page, I'll mention just the special committee from this summer. As I talked about the IDD waiver earlier, the waiver for people with intellectual and developmental disabilities, 9,000 and some people served, more than 4,000 waiting for services, a waiting list that, despite the best efforts of the legislature and funding, that waiting list pursues, just continues on. So the Special Committee on IDD Waiver Modernization, led by Representative Carpenter this summer, really spent the interim looking at what opportunities there might be to look at some new options. And so the recommendation from that committee is to consider development of a new community supports waiver as a possible additional 8th waiver. Under the developmental disability waiver, it's kind of what we think of as a full service waiver. So it includes day services, employment services, residential services. The community supports waiver would be more streamlined. It would only be targeted really more to those individuals who can live more independently or who are living with family and wouldn't need those residential supports. So again, we're in the process of putting some information together on that related to costs and things like that. And I know this committee will have some more look at that this session. Again, an opportunity that many states have taken to have a more streamlined waiver to meet some of those service needs that are unmet today. So that's kind of the LTSS Commission. As I said, it's community-based and services plus nursing facilities. If you think about the aging, you think about people with disabilities ranging from autism to physical disabilities to brain injury, kind of the gamut of disabilities. And these are the kind of Medicaid, primarily Medicaid health supports, but some state general funded supports that support those individuals. So the second of 4 commissions within KDADS is the Behavioral Health Services Commission. And this is the commission that manages KDAD services that have to do with mental health or addiction, substance use disorders. The federal government through HHS has a division of HHS that's called SAMHSA, the Federal Substance Abuse and Mental Health Services Administration, and KDADS is designated as the single state agency for substance use and mental health by SAMHSA in Kansas. So mental health services contracts with community agencies, primarily community mental health centers, but others as well, to provide services to individuals and families who experience mental illness. Again, with a focus on least restrictive environment. The same with the substance use side. Again, contracts to provide services, both treatment and prevention services related to addictions use. Really trying to ensure that there's a continuum of care that's available and accessible in every region of the state. For example, on the substance use side, there can be a range of things from outpatient to intensive outpatient to inpatient residential services on the substance use side. KDADS has also been playing an important role as we think about the opioid epidemic that's really impacting the state and the nation. We've received a number of resources through the federal SORA grant, which stands for State Opioid Response Grant. And for example, we've been able to distribute about $2.6 million for statewide naloxone distribution through our partner ADECA. So behavioral health, I've got a little bit of a chart for you on page 11, really talking about behavioral health modernization. This is an area where there's been a lot going on, both within the agency, across the nation, and also through legislative activity by this body for the last few years. One of the most important activities happening right now in Kansas is the transition to what are called CCBHCs, Certified Community Behavioral Health Clinics. Kansas today has community mental health centers. You have one in your area. You can probably name them in your area. The legislation that you passed a couple years ago would allow those community mental health centers to transition to become CCBHCs. A couple things happen with that. One, they begin to receive reimbursement that's cost-based as a CCBHC, so there's going to be higher reimbursement rates to those entities. But in exchange for that, they have to provide a whole array of services. And this is a program that started federally. We're doing it kind of led from the state side, but we're really modeling it after the federal program. So, for example, they have to provide crisis services, they have to provide addiction services. There's an array of services they have to provide. They also have to ensure they have capacity to not have waiting lists, to be able to meet service access needs. So again, significant change. The way the legislation was established, it was over a 3-year period that those mental health centers would transition. 9 have transitioned thus far and have provisional licenses as CCBHCs, 8 more by the close of this fiscal year, and then the final 8 by the close of the next fiscal year. This is probably, this really is, I think, the most significant change in mental health and in terms of the ability to impact access to services really in a couple of decades in Kansas. A lot of other things are going on as well. You'll see on this chart, and I'll talk a little bit later, you'll see state institution alternative beds. In response to some of the capacity issues we've had at state hospitals, including the moratorium that was in place at Osawatomie for so many years, We began a couple years ago contracting with private hospitals for psychiatric beds in the community. So individuals who might otherwise go to Osawatomie or Larned for psychiatric services could stay closer to home. It's been a good program, but the one thing I would say about it, it doesn't in and of itself increase bed capacity. If those facilities have bed space and a person can get those services close to home, that's great. But there's some other things going on related to bed capacity as well. So that's been important. A lot of things going on as well in behavioral health related to crisis services. This legislature funded through lotto revenue a few years ago, funding to create crisis stabilization centers. We have a number of community mental health centers that have created those centers over the years to provide short-term crisis stabilization in the community. Also, the Crisis Intervention Act to be able to serve people, again, for short-term stays in the community who are involuntary patients. So a lot going on in that realm, and that all ends up connecting to the state's work around 988. So, Kansas is one of the few states that passed statutory authority around 988 last year, as well as $10 million in a demand transfer to fund those call centers. Andy Brown, who's our Commissioner of Behavioral Health, is chairing the task force that legislation set up. So they've met a couple times, and I think we've also turned in the first reports related to 988. Kansas is doing well on 988 in terms of people answering the phone when 988 is called. Like all states, we still have work to do to build up what that crisis response looks like. It's like if you called 911, it's great that they answered the phone, but you sure want them to have an ambulance to send out to your house, right, if you need that. And 988 it's a bit like that in the sense of thinking about what are those array of services. So including mobile crisis response across the state. So again, a lot of pieces going on in behavioral health. On page 12, I've called out a few of those. Again, I'll try not to repeat the things I've already talked about. Again, it speaks to 988. It speaks to we've expanded the contact center so that most calls are answered in Kansas when people call 988. We have a state suicide prevention plan and have launched a state suicide prevention coalition. I might mention the last bullet. We awarded a contract to KBC Hospitals to open an acute psychiatric hospital for youth in Hayes. It will also serve as a state institutional alternative, a real gap in terms of services for youth in the western part of the state. And the ribbon cutting for those doors to open will be this Friday, and that hospital will start accepting kids next week. So again, a real need in western Kansas. Really excited to see it at this space to have those beds opening and being able to be used. So. All right, so that's kind of behavioral health. The third third of four commissions I wanted to talk about are survey certification and credentialing. And again, this is our commission that inspects and licenses adult care homes and providers of disability and behavioral health services. So it's not just nursing facilities, but a wide array of providers in the realm of disability and behavioral health services, as well as adult care homes. The largest portion of our staff, really about a third of our staff, more than a third of our staff are our surveyors. So we actually function with regard to our nurse facility surveys really at the behest of the Federal Center for Medicare and Medicaid Services. We're really conducting those surveys on their behalf. So our surveyors are across the state, and they do both the regular surveys under sort of periodic schedules, as well as responding to complaints or concerns of abuse or neglect. As you can imagine, this was a very, very, not that all the areas weren't, but this was a very, very busy area during the pandemic, particularly in those early days when not very much was known about COVID. In rare cases, the commission can also assume temporary management of a nursing home facility pursuant to a court order. And at one point, Kansas had 20-some homes under receivership. We're down to one right now. All but one, I think one closed early on. All the others were transitioned to new providers. So we're down to one that we're still managing in receivership. So we're really, really pleased and proud about that. In terms of some of the areas of focus, I mean, what I just said, continue to pursue a buyer for that last nursing facility. We're finalizing the crisis intervention center regulations for involuntary placements. I think those are back with the Department of Administration again. So that's been a bit of a long process, and at one point we had to kind of restart that regulation process, but it is back in the hopper. Right now, a lot of the focus of our survey group is just focusing on the backlog of certification work that was created during the public health emergency. There was a long period of time where our federal partners just had surveyors not go into those facilities, not really wanting to put the elderly at risk. And so except for, really serious situations or complaint things. So again, like all the states trying to catch up on those. Also, really continuing to work hard with provider groups and others to look at ways to impact workforce issues. There's credentialing of a number of provider groups that we do through this commission, and just looking at some ways to find some ways to address some challenges people are having. We know workforce challenges are everywhere, so again, we're actively at that table with the Survey Certification Commission. Last commission, State Hospital Commission. As I said earlier, we oversee 4 state hospitals. And the commission provides day-to-day management and collaboration with our superintendents and our executive staff, and a lot of engagement with stakeholders, whether that's in Topeka or across the state, whether that's law enforcement or community mental health centers, cities, counties, other providers. In terms of our state hospitals, I already talked earlier about a little bit about those 4 hospitals. Two hospitals for people with developmental disabilities, 2 state psychiatric hospitals, and then what I call kind of that expanded footprint at Larned, where we really have the forensic piece around competency evaluation and restoration, and the sexual predator treatment program that makes that, as I said, a bit of a different animal. In terms of priorities and accomplishments, we did lift the moratorium on voluntary admissions at Osawatomie in January 2022 after several years. And again, that was possible due to the availability of the SIA beds and also progress on remodeling projects at Osawatomie. We're currently in the process of another remodeling project at Osawatomie that, when completed, will expand some bed capacity there. A huge piece on the state hospitals, and Deputy Secretary Bruner's here as well, but, a huge area of focus has really been on workforce. As entities that, have a wide array of staff in those facilities, some of which are very similar to the direct care staff in the communities, we have been really, really challenged on the workforce side. And that's really been true across our hospitals. The most challenging circumstance, though, has been at Larned State Hospital, where we've had to rely in a really, really significant way on agency or contracted staff. We appreciate the recommendations that were made in the past session related to a 24/7 pay plan. That's still really, really important to us. I know there's been a lot of conversation about, is this temporary, is this permanent? Our workforce challenges have not eased. So that's very critical to us to continue to have those resources. We're doing a lot on the recruitment and retention side. I didn't put a lot in here, but you'll hear that when you do the budgets. You'll hear that from the superintendents, some of the innovations around recruitment and retention. Another area of kind of priority in the state hospitals has been around the issue of competency evaluations. You know, we have a backlog of evaluation and restorations at Larned State Hospital. That means people are staying in jails. I'm sure you have, if you haven't heard that, you probably will hear that sitting on this committee about some of the challenges that are some local jails are experiencing. You allowed us last year to change our law to allow more of those competencies to be done in a mobile way and to expand those evaluations. We've entered into a contract with community mental health centers. We also have some pilot projects going on doing actual restoration in the community. Those numbers are pretty small. I don't want to overstate that, but we're certainly implementing that and looking to see what impact that's having. But again, you'll hear more about this on the budget side as we talk more about that. But again, a lot of focus for us over the last year and a half on that whole issue of competency evaluations. And then we're also in the process of implementing electronic health records for all 4 state hospitals. It's a very intense time right now on all those campuses as we begin to look at training and begin to looking at implementing those systems. It's not a short process, and we're only a couple decades behind the private sector, right? So, well, very much needed. The last thing I would say on the state hospital side has to do with the Special Committee on Mental Health beds. Last year, the governor supported $15 million in the KDAD's budget to look at opening a 50-bed state facility in the Sedgwick County area. The legislature last year added a budget proviso that created a special committee that met during the interim. Based on the report from that committee, the Finance Council has now released that $15 million to us as of December. We've just hired a project manager to work on the project, and this intersects as well with some of the SPARC resources coming out of the recommendations from the SPARC committee. But the plan for this is 25 beds related to forensic competency, 25 beds for acute inpatient psychiatric services. And again, there were a couple of other recommendations from that special committee to select a site that would allow expansion beyond 50 beds, and also some recommendations to reimburse hospitals or jails that are holding patients that are waiting on transfer to state hospitals. So again, that's kind of a quick overview. I'm happy to answer any questions you might have, Mr. Chairman. And
Thank you. As we started down this road and looking at 101s, this is just exactly what we were looking for.
thank you.
4 of the members on this committee out of 9 are brand new to this, so this is very helpful. Questions, committee? Representative Droege.
Thank you, Mr. Chairman. I had a question on the difficulty in hiring staff and the 24/7. Are there still COVID restrictions on them, vaccination requirements, or?
No, there were some requirements that came down federally for a while, and I think they've moved that back now, Scott, haven't they? Yeah. There are no requirements at this stage. Yeah.
Committee, other questions? Representative Ballard.
Thank you. I'll follow up on Representative Droge's question. Okay, so they have lifted those restrictions, but what's the biggest problem we have with not being able to hire sufficient staff?
I think that's a hard question to answer with just one thing. I would say it's a little bit different based on the part of the state. Right now, there's a lot of competition for healthcare resources. If I were to talk about Larned, I mean, I would say the main issue at Larned is that there just aren't enough people. If you look at the number of people who are unemployed in that area at any given time, sometimes that's in single digits. And so, for Larned, short of really recruiting people in from other areas, there just aren't enough people to fill the needs that we have there. I think it's a little bit different in other areas. You know, in terms of if you go, for example, Osawatomie, you're going to get into some of the challenges. If you think of maybe the higher level professionals, nurses and registered nurses and the like, where you really have competition with the metro area, with the KC metro area, and so that's a real difficult salary competition there. So to me, it really depends on where you're at. I think what that biggest issue is.
Thank you, Mr. Chairman. And the reason I asked that question is because you hear on every committee there's a workforce problem, but it doesn't mean that it's the same everywhere else, you know, every part of the state. In some areas, what we found out, there's a housing shortage. So really, in this case, if you hired them from there, where would they live? Because they don't have available houses for them. So now you give them somewhat of a bonus to cover the gas or the mileage if you have to drive in. Then it comes down to maybe it's an hour and a half to 2 hours to drive, and then it's an hour and a half to drive back. So there's all kinds of problems, you know, when he asked the question about workforce, then just people don't show up, or you don't have enough people, or nursing staff right now, the salaries are so competitive in terms of you may want to work 4 days, you off 3, you know, and so but you need somebody all the time. And we are trying to cut back on overtime because our overtime was unbelievable. But then that created another problem because some people were working 16 to 18 hours, and now you don't want that to happen. So there's lots of reasons for it. Am I correct?
There are, Representative, and as you said, at several of our hospitals, I mean, just the level of overtime really unsustainable. I mean, just in terms of people's well-being. I mean, Secretary Zamuda would say the same thing about the prisons. I mean, in terms of the number of hours that people were working. And again, we have had to rely a lot on kind of the contract traveling staff at really, really high costs. That's an interesting one. You know, we have new contracts now that I think reduce some of those rates down a bit. But I think that's another one to sort of see how that plays out. I mean, I think there were a lot of people across the country who kind of jumped on that bandwagon, thought it sounded like a good deal, but I don't know if people are going to really want to do that work, be away from their homes, even for really high dollar amounts forever. So I think we're hoping that some of that also will moderate and allow us to hire more staff. But again, I mainly just wanted to stress that this continues to be huge area of priority, huge area of concern as we manage those hospitals. And again, you'll hear from, when you talk about the KDOS budget, you'll hear from all of our partners as well. I mean, obviously, I was speaking more about the employees that we hire directly. But for example, one of the pieces even around the CCBHC was the ability to compete with some community mental health centers from other states who've gone down that path and are able to pay significantly higher rates for those workers. So.
Thank you, Mr. Chairman, for allowing me those questions, because, you know, often we say, well, we have a workforce shortage, but I guess the point I really wanted that the Secretary did address, that we're not just talking about it, they're trying to do something about it. They're trying to increase it. It's just not easy because it's everywhere around the state. Every committee I'm on, and when we're in appropriations, we talk about that too. So I'm glad you're still working on it, because that is a dire need in our state, but not just Kansas. It's in all 50 states. Thank you, Mr. Chairman.
And I think Representative Droege had a follow-up. Is that correct?
Yes, thank you, Mr. Chairman. Thank you, Ms. Howard, for your presentation. Just along the COVID thing, are masks required for employees?
It depends on the level of transmission in the community. So sometimes they are and sometimes they aren't. And I might ask my Deputy Secretary, if you don't mind, if I need any clarification on that from the standpoint of our hospitals. Is that? Yeah. So again, he indicated that depends on the level of transmission going on, or for example, if there's an outbreak at the facility, then people would be masking up. It just as happens at nursing homes. I mean, under the federal requirements, mask mandates are lifted, but then if there's an outbreak, they're certainly placed back on during the course of that outbreak. Within the facilities, those wouldn't be the cloth masks. No, they would be the N95 masks.
Representative Clifford?
Thank you, Mr. Chairman. Just a logistical question. Maybe Lee could circulate the memo about the KVI open house groundbreaking or ribbon cutting on Friday.
About
'Cause
KBC,
I'd
sure.
like
Camber
KBC.
Health, yes.
I'd like to go.
Yeah, Camber Health, yes.
I've lost all my emails regarding that, so I probably can attend.
Yeah, that'd be great. Yeah, Camber Health. I still call them KBC. They've renamed their children's behavioral health portion of their agency to Camber Health. So but yeah, that'll be Friday afternoon in Hayes. So, yep.
Representative Donahoe?
Thank you, Mr. Chairman. There's one of the facilities that treats substance abuse. Okay, so what is the position of the Kansas government with regard to legalizing marijuana when you have a facility to help treat that to some regard?
We don't have a position as an agency with regard to that. I know obviously you're having a lot of conversations during the legislative process with regard to the issue of medical marijuana or marijuana as a whole. But at this point, that's still a substance that we would provide treatment for, if a person sought treatment through our provider network.
So have you seen increases in the number of people treated, that type of thing, increased cost based upon what's transpiring in other states and coming into Kansas?
We really haven't on the treatment side at all. I mean, frankly, our focus on the treatment side right now, where we really are seeing the needs right now, is really on the opioid side.
So, last question.
It had been meth, and now it's really opioids.
So, have you looked at other states and checked into where they've had legalized marijuana for some period of time, how it's affected their state-owned facilities where they're potentially providing care also?
I don't know the answer to that, Representative. The one thing that I know, really from a role I was in before I was in this role, where I was the regional administrator for SAMHSA, I do know that, like with the Colorado experience, one of the things they saw that they felt like it was important was just resources and supports around prevention as it relates to youth. That was an area where that state, when they kind of did their lessons learned a few years in, felt like they should have invested more of attention and focus on the youth side, but I don't know the answer to that other question. I could certainly ask our federal partner. The prevention side, but as it relates to youth, just more education for youth as it relates to prevention when they were implementing that.
So you have a state that's saying they wish they would have counseled people more to not utilize or to not indulge.
Yeah, on the youth side, really to educate youth about the impacts. So yeah, I mean that's what they've said, and they've since invested additional resources on that side in Colorado. But I don't really know beyond that, Representative.
Thank you.
Committee, other questions? Representative Barth.
Thank you, Mr. Chair. Thank you, Secretary Howard, for the presentation, and kind of heard this a couple times, I think, a little bit now with being on the Health and Human Services budget as well. But I did have a comment just around the Osawatomie State Hospital. Back when I was running for office just in 2022, I did have a call with the superintendent, Mike Dixon. He was the interim superintendent. He also is responsible for Parsons. And specifically in like Osawatomie, they did not have as many of the challenges around finding people to staff. The challenge was being able to pay them enough competitively. And the state legislature actually took care of that, and he was pretty happy with that. So I think that's really good news that they did not have that same type of issue from what I've been told. I have not had a chance to speak with the new superintendent, I think it's Ashley Bynum.
Byram.
Okay, Byram. I did have some questions, though, and when she talks about the hospital having, or the prisons having folks in it, too. I've actually been to the Miami County Prison, where they do have patients being housed there, getting them access to evaluations or just having the evaluations in that scenario where they're not even able to get the care that they really need is kind of a challenge as well. So those are some things that hopefully there's some solutions for. I did have a question around, on some of the numbers, I was surprised on the waivers for autism. So I think you said there were 58 people. I know we have sometimes in the communities 58 people. So across the state, what does a waiver look like to qualify? What age do you have to be, and what does that entail?
Yeah, we can get you some more details on the autism waiver. I think I'll have more details in my Thursday presentation. The one thing I would say about that is there are people, we don't create a waiting list in quite the same way, but there's about 400 people who qualify for the waiver who aren't on it. But the one thing I would say about autism is that some of those services have been put into the regular Medicaid state plan. So for families where there's Medicaid eligibility, they're able to access some of those supports. And that's been true for a few years now. But I'm happy to make sure that if that's not in our presentation for Thursday, I'll get those details back to you.
Okay. Thank you.
Committee, other questions? Yes, Representative Carpenter.
Thank you, Mr. Chair. I didn't want to monopolize everybody else's questions here for a minute. I did have some questions, Madam Secretary, and thank you for being here. I've gotten to know her quite well over the last few years. So on the 10% increase in FMAP, I believe I've asked for those numbers. So the first deal was 75 million. Now we've collected another 18 million, and it ends when the public health emergency ends. So we're obviously going to get some more money. So what is the plan? I mean, there was a very detailed plan for the first 75 million, and I've asked for this in the past, what your plans are for the future. You don't have to get it to us today or bore the committee with those answers. They may not have even want them. But anyway.
We can get that to you as you enter into budget conversations, absolutely. I mean, I think there's still some dialogue about some of that increase. I think one of the arenas, I think you and I may have talked about that we wanted to spend some resource on has to do with some of the technology innovations. I think we talked about that this summer. So that's one area. And I'm not recalling a couple of other things that were recently talked about with some stakeholders, but we'll put it together so the committee has the full updated detail.
Yeah, that would be great. Yeah. And the technology is just out of this world. We had this interim committee for the summer, and they've just taken technology in these houses and homes and stuff so they've done cameras where they can watch, I mean, just a whole bunch of things where it's a safety issue, but it's also workforce friendly too. You can use less workforce and still monitor the same amount of people. It was incredible. But that's kind of where I was coming with that is if there's any emphasis on spending money, might be in that direction.
Yeah, that's definitely an area that we've added to the list. So
okay, for Scott, he knows. Scott, how much have we spent on overtime at Larned this year? This will blow the committee. Apologize for that, Mr. Chairman.
Scott Bruner, Deputy Secretary. I'd have to look at the I can probably do the research while you're still asking questions of the Secretary and get you the actual.
That's fine. I just want the committee to know that it's millions and millions of dollars.
In terms of contract staffing.
That's what I'm talking about.
Oh, for the contract staffing, through the end of December, we were close to $27 million, I think we've spent on agency nurses. That represent about 250 nursing staff. So, and you can do the division to figure out what that is per nurse, but it's 2 or 3 times more than we pay our FTE staff nurses.
Exactly. So I just, for the committee's reference, that is an incredible amount of money, and we still can't staff properly with that kind of contract labor. So another question for you, Scott, again, contract on with, what was it, Heartland or Wheatland? The CCBHC, or the community mental health centers to do competency and evaluation?
Yes.
Okay.
So it's with Wheat State, which is the practice association formed among the community mental health centers. So we could contract with one entity and access all of the providers in the CMHC system through one agreement, as opposed to going out to all 26 and having separate agreements with each of those. We've got the agreement drafted. I can't remember whether it's in our hands or with Wheat State. But we've come to terms on the rate per evaluation and per restoration, and I think we're just trying to get the terms finalized so that we can get that executed. And
So you need some help? You need some help?
I need help
finalizing
in
that?
lots of different ways.
It
But I
was.
think that one's well in hand. And
No, that was a proviso in the budget. And so I've been watching that patiently. But anyway, to reference what Representative Barth said, when we left session last year, there was 163 people in jails and hospitals and stuff like this awaiting competency evaluations. And so you saw that one page where the hospitals and the jails are actually asking for some recouping of their cost. It was $5 million. But second thing is we've got to get that done. But the other thing is we don't have a place to put them after we figure out whether they're competent or not, because we don't have the bed space. So anyway, enough of that. Just back to the suicide hotline, last year we were number 9 in the nation for suicides. So that's kind of why you saw a big push for suicide prevention in the 988 hotline. We were number 9 in the nation. So that, but anyway, that's enough of my questions. Thank you, Mr. Chair, for indulging me.
Quite all right. Thank you. Representative Hobson had a question.
Thank you, Mr. Thank you, Mr. Chairman. Question for the gentleman. Just to follow up on Representative Carpenter's inquiry, with respect to the money spent on nurses, were they 1099 contractors, or were they, you spent $27 million? Is that my understanding?
we have, the state has contracts with nursing agencies, staffing agencies, so we use those as the vehicle. So the state procurement office does a generalized contract that serves our state hospitals, the state veterans homes, those two primarily. And so there's a single state contract that then's offered out to multiple staffing agencies so they can each put a cost proposal against that state contract. So they're not 1099 employees. We're actually paying a contract agency for those staff. We use about 5 different agencies to fill our needs at Larned.
Is it fair to say that some of these nurses were travel nurses?
Yes.
Okay, so in other words, there were contractors with how I put it, kind of what she was talking about. So we're just being paid with, not necessarily have benefits per se. Is that my understanding?
There's a mix. Some are, their contracts include paying for health insurance and other kinds of things. Some are more traditional kind of 1099 contract that they don't receive benefits. But I think the typical one, they do get some kind of benefit through their staffing agency that pays health insurance.
Okay. Just to follow what the question. Okay, that's all. Thank you very much.
Representative Ruiz.
Question for Deputy Secretary. Yeah.
I'll be more patient. I apologize.
I think you might know this. And anyway, so have had I've been hearing some conversations about maybe looking at statute regarding involuntary commitments and it related to the competency of being able to make some changes to that statute so the person doesn't actually, you know, if they're being charged with not a felony, I guess, that they maybe would be able to remain in the community under some kind of supervised care, but and receiving mental health services on an outpatient side. Have you heard anything about that?
Yes, the existing statute allows something called an outpatient treatment order. So the court can order a criminal defendant to order them to treatment in the community and say, as a condition of your release from jail, you'll attend therapy or you'll go to your medication management appointments. And if the defendant violates one of the terms of that outpatient treatment order, they could be brought back into custody and then kind of go through the traditional adjudication process. Could involve competency or not, but that is an option under current statute. There are some discussions. There's a group of judges and defense attorneys and prosecutors that are just trying to figure out other ways to either make that easier to use or more capable, and also even looking at the competency statute to now, if while you're waiting to have your competency either evaluated or restored, you're somewhere, either at a state hospital or in a county jail, to have that count towards your time served, whatever your eventual criminal offense would be, and what the sentence would be, that you're essentially running the clock at the same time. That would require statutory changes, my understanding, but outpatient treatment orders are available, and you could ask others that know more about it if there would be some flexibility, so it'd be more helpful. But we do see a good number of outpatient treatment orders around the state.
Thank you.
You're welcome.
Representative Ballard.
Thank you. You can stay there too. Question I would have, Representative Carpenter mentioned FMAP,
Yes.
and we kind of went over it quickly. Would you just explain FMAP and why it's so important?
I can try. So in the Medicaid statute, Medicaid's a state and federal partnership program. And the partnership is the federal government will match state dollars that are put in to pay for Medicaid services in a percentage that's tied to essentially the poverty rate in your state relative to the other 50 states. And that's called the federal Medicaid assistance percentage. You were going to throw me off by putting extra letters in there, but the federal medical assistance percentage. And it sets up what that ratio is. And in Kansas, it's about 40% or 41%, typically state dollars, and the other 60% come from the federal government. And one of the things that the administration and Congress has done through the pandemic is use that funding mechanism as a way to drive federal dollars to states by raising the federal percentage, which has the effect of lowering how much state money you have to put in to match. And it ends up being dollar for dollar. For every percentage you put in of more federal share, that frees up that percentage from the state side. So that's the typical way for services and through the Medicaid program. The FMAP incentive that the Secretary was talking about that we're using for other programs uses the same thing. It's just a much bigger chunk. It's taking 10% of that percentage and then allowing the state to use that 10% of the state share that was freed up. Is that close?
Thank you, Mr. Chairman. I
don't have my charts and graph with
I
me
asked
that I
that
typically
question
carry
because
around.
often when I try to explain it, it is complicated because it doesn't stay the same all the time. You know, and so you can't just learn it one way because then something else happens. But initially, as long as COVID was up, we paid a smaller share. You know, so, but at some point it goes back up. So we have to make sure we're able to cover it when that does happen. Okay. Thank you, Mr. Chairman, and Representative Ruiz has another.
Representative Ruiz.
Thank you, Mr. Chair, for the second question. Deputy Secretary, if we were able to expand Medicaid, how would that affect workforce? Maybe salaries, perhaps?
I know a little outside of my area for that, but like on the FMAP projects, working with direct service workers, so people that provide in-home care or support to individuals with disabilities on the HCBS waivers, they're very low paid, very low wage, minimum wage, not above the minimum wage, but between $12 and $15 an hour, I think is probably fair, at a wage where those employers probably do not offer health insurance, but they would earn enough that they would qualify for Medicaid, so as the worker themselves. So there'd be a benefit to those employees to have another source for health insurance that either isn't on their own dime buying through the exchange, health insurance exchange or through their employers. That would be one possibility. For our state employees at the hospitals, we do appreciate what you all did with the 24/7 pay plan to provide those differentials, and we did raise the base pay for our direct service workers up to $16 an hour, and with the differentials now, we're close to $20 an hour for those employees. And they, of course, get state benefits with that and health insurance. But I think probably the biggest for Medicaid expansion would be for those direct service workers on the home and community-based service programs.
Thank you so much.
Thank you. Committee, other questions? If not, I have one either for you, Scott, or the secretary, and I'll ask it and see which one of you wants to answer. So I'm just kind of going through the machinations in my mind of the special committee, and the special committee recommended adding an 8th waiver, which was the community supports waiver. So just logistically, how does that work? I mean, is that ours to just say we want this new waiver, or must we then apply to CMS, or how does that work?
Yes, well, it's a fairly extensive process federally. So once, if the state wants to implement a new waiver, we have to go through a lot of work to develop a waiver application. We would do that collaboratively with our partners at KDHE as the state Medicaid agency. We work very well together on that. And then it takes quite a period of time to get things reviewed and approved through CMS. So I think like this summer, I'm not remembering exactly the testimony, but when we kind of talked about kind of the time frames, I mean, I think we were talking, you know, we're probably just that approval process, we could be like in 9 months to a year. They start out, you know, we would turn something in. They have a certain period of time to respond back with questions they have. They usually wait and let the clock tick for those 90 days or whatever it is. Send back the questions. It may take us then a few more months to respond back. So again, it's a fairly extensive process, but we have a lot of experience with our federal partners. We have good relationships with the folks at CMS who would be doing this, as well as I think we have the benefit of the experience of other states who have those types of waivers, including some of our neighboring states. So, I mean, my hope would be that should the state move forward in that direction, that we'd be able to kind of get a leg up on that process and maybe not run into as many questions if we are able to kind of maybe mirror it after some things that were successful in some other places.
Thank you very much. Committee, last call for questions. Yeah, Representative Carpenter.
Thank you, Mr. Chair. I just wanted to, so the timeline is that our current waiver expires in 2024. So we have this period of time here to apply for that waiver. One of the things that I lack, or I think we lack on this, is a fiscal note. And KDADS is working on the actual cost or projections for that. But we wouldn't have any bill due for probably 2 years on this waiver because it won't be implemented more than likely for 2 years. So.
That's right. That's exactly right. Yeah, and we're finalizing at least a first draft of a fiscal note with some of the assumptions that the interim committee made, and we've been costing out those things, and you should have that in the coming days. So.
I'll save my spiel for what will be Thursday. That we'll be hearing and then you'll get a full blast of Representative Carpenter on how important this waiver is. And Representative Clifford was on that committee also, and Representative Ballard too. So it was fun and interesting. So thank you.
I will look forward to that. Yeah. Okay, last call. Questions, committee? Thank you for your kind attention, and thank you for the presentation. It's exactly what we were looking for. We're adjourned.